It is my pleasure to introduce our first speaker, Dr. Chris Harvey, who is a longtime friend and colleague. We've researched together, worked with contrast together for many, many years. He is a consultant radiologist at Imperial College, and he is the chief of ultrasound at Hammersmith Hospital. He has published over 50 peer-reviewed papers, and we've also recently written a book together on liver ultrasound. And he's delivered many invited lectures and also runs some contrast-enhanced ultrasound courses. He is going to speak to us today about characterization of incidental liver lesions with contrast-enhanced ultrasound. Thank you very much, Chris.
Thank you very much, Adrian. Can you see my slides? Lovely. So thank you very much for Bracco for inviting me to do this talk. And I'm going to show you how useful and versatile and what a great technique contrast enhanced ultrasound is, especially in the characterization of liver lesions and incidental liver lesions. So incidental liver lesions are those detected in a patient that has been imaged for an unrelated reason. And they give a rate of sort of 30% of patients who are more than 40 years old and 50% of autopsies. So this is a huge problem. The good news is that majority are benign, but unfortunately on ultrasound, they're indeterminate. So it'd have to go off and have CT and MR for further characterization. So all these incidental liver lesions have significant potential morbidity, mortality, patient anxiety, and massive expense implications. So the way to tackle them when you're doing ultrasound is to look and see if there's any risks. And the big risks are cirrhosis, liver conditions such as hepatitis B and C, alcoholism, NASH, sclerosing cholangitis, and primary biliary cirrhosis, and whether there's abnormal liver function tests and whether there's a known malignancy. You should also always compare with modalities and not just with the previous ultrasound. And as I tell our sonographers, look at the CT and MR and see if it's been found before, because not commonly a hemangioma would be noted a few years ago. So I always ask them to look at the CT report or MR report, as I know that sonographers are not typically happy to look at CT and MR images. And then you must know whether the patient is symptomatic in terms of whether they've got a fever or weight loss or pain. So the problem is so huge that the American College of Radiologists produced guidelines in this white paper on what to do with incidental liver lesions. But fortunately, we don't need CT and MR because we've got these magic microbubbles. And characterization of focal liver lesions is the principal application of these. Just a brief recap here. So microbubbles are a bubble of gas, usually a high density gas such as sulfur hexafluoride, surrounded by a phospholipid shell. And the one that we use in Europe and Asia and now the USA is Sonoview. So the size of a red cell, they stay within the vascular tree, and by sheer luck, they resonate at the everyday frequencies that we use in ultrasound. We can use real-time low acoustic power modes to image them for up to 5 minutes, and we use low MI modes to decrease the destruction. And that compares to CT and MR, which are just snapshots in the arterial phase or portal venous phase. They're very safe, no nephrotoxicity, as you see in contrast CT contrast agents, no risk of nephrogenic systemic fibrosis in MR agents. And of course, you can use them when MR and contrast agents are contraindicated. Now, coming from the same stable as Adrian, we've got a bit of overlap here. But as he pointed out, there's guidelines now, and this systemic review has shown that contrast ultrasound is as good as CT and MR in the characterization of incidental liver lesions, those detected during surveillance of cirrhosis, detection of metastases in colorectal cancer, and contrast ultrasound is more effective than CT and MR more cost-effective in the characterization of incidental liver lesions and those detected during surveillance of cirrhosis. And this one's already touched on again, a pediatric group. So massive cost savings, as Adrian pointed out, no ionizing radiation, no contrast from CT, no need for sedation for MR. And again, this modeling study compared a world with and without contrast agents, if you can imagine such a hell. And with current sort of base use of 5%, this represents a 224,000 pounds saving to the NHS. And this escalates massively when you sort of model up to 50 and 90% with over £2 and £4 million saved, which would be an astronomical amount of money saved. Guidelines, we're up to 2020 now in the latest liver guidelines, and it's gone through multiple iterations as the technique has evolved over the 20 years, and it's backed by those nice people at NICE. So the contrast is mainly used for characterization of focal liver lesions. That's the most evidence-based that we have. And contrast ultrasound significantly improves the sensitivity and specificity of ultrasound in the detection and characterization of these focal liver lesions to rival that of CT and MR. Contrast ultrasound has got a much higher spatial and temporal resolution than CT and MR. And we can image the microcirculation, which is not possible with conventional Doppler. So conventional Doppler, you can get down with sort of vessels of 1 millimeter, but with microbubbles, you can get down to sort of 100 microns. It's an easy to learn technique, real-time imaging, very safe. And as the most proportion of liver lesions are detected by ultrasound, it's only right that we can go straight on and characterize them immediately, saving patient anxiety, waiting lists, and lots of money. So the guidelines say that contrast ultrasound should be the first-line technique for the characterization of focal liver lesions detected on ultrasound, which is certainly not the case in the UK at the moment. Characterization on contrast ultrasound is superior to CT and equivalent to MR. And contrast ultrasound has a high sensitivity in the detection of metastases compared to CT and MR. And one meta-analysis showed a sensitivity of 93% in 8,000 lesions. So ultrasound contrast is recommended for further assessment of indeterminate lesions on CT and MR and PET prior to biopsy, but it's not recommended in the routine surveillance of patients at risk of HCC or for staging of HCC. And that's because we can't reliably cover the whole liver in the arterial phase. And HCC can have variable washout that I'll talk about later. But having detected a lesion, we can use CUS LIRADs to characterize focal liver lesions who are at risk of HCC. So here we have 6 different lesions detected on ultrasound. And unfortunately, all these would have to go off to MR and CT. We'd never hear from them again. We'd never know what happened and what the result was. Conventional Doppler doesn't help us really in the characterization. So as we go through the talk, we can see what all these lesions turned out to be. So immediate characterization. And how we do this is looking at the vascular phases. So arterial and portal venous, as on CT and MR, but you've got this other sort of more specific phase that from microbubbles called the late phase, where the bubbles stick in the sinusoids, and that occurs after 120 seconds. And in that phase, anything that hasn't got sinusoids will be a defect, which is very helpful in the characterization of malignant lesions, as we'll see later on. It also sticks in the reticular endothelial system of the spleen, but the kidneys do not have a late phase. So here's the typical focal lesions that you'll come across in the liver. So divided into benign and malignant lesions. So the malignant lesion, you can see there's one called non-hepatocellular, and that would be covering metastases lymphoma, and cholangiocarcinoma. And then you can see that there's arterial and portal venous characteristics. And the benign lesions tend to retain contrast in the late phase and portal phase, whereas malignant lesions tend to wash out. But on top of that, in addition, some of the benign lesions have specific enhancement patterns. So hemangiomas show this peripheral globular enhancement with fill-in, and then don't wash out. Focal nodular hyperplasia shows avid enhancement in the arterial phase from a central feeding vessel, which spreads out in a centrifugal manner. The malignant lesions tend to enhance to some degree in the arterial phase, but then wash out. Metastases wash out early, but HCC can wash out variably according to how well differentiated they are, whether they're well, moderate, or poorly differentiated, that we'll talk about a bit later on. So here's a sort of setup. So you'd have a dual display. Here's the focal liver lesion here, really, really subtle. So you'd get that focal liver lesion in the sort of longitudinal phase, so that when the patient breathes, just small breaths, it stays within the field of interest. If you image in the transverse plane, it can go in and out of the plane, and you might not be able to see it throughout the whole exam. So you make sure the liver lesion is within 10 centimeters of the skin surface. Your focal zone is put down here below the liver lesion. And you want the contrast side very dark, so you can just see the outline of the liver. And then the B mode is an altered B mode, so it's a decreased power. So it's not as good as conventional B mode. So you can see the timer is here, 7 seconds, and then off we go. And as the contrast comes in, it's like turning on a light bulb. So the lesion avidly enhances in the arterial phase. And then what you would do is you'd follow that. So it's just flashed it there, actually. So just put a high energy flash and then revert to low energy again, just to watch the reperfusion. Once you've passed the arterial phase, you image every, say, 30 seconds, just for a short period of time to minimize bubble destruction, because you're looking for washouts. So washout means malignancy. So anything enhances and then washes out is malignant. And you can see here that we've gone to almost 2 minutes. The lesion's now disappeared. And this is a benign lesion, but we can say from the arterial phase that it's got this avid enhancement, which comes from a central feeding vessel spreading out and a spoke wheel centrifugal pattern. So this is a classic focal nodular hyperplasia, completely benign. So we characterize this lesion. We can reassure the patient, and that's the end, really. So no patient anxiety, no MR, no CT, and big cost saving. So going on to benign lesions. So here's a simple cyst. Now, of course, the vast majority of simple cysts you don't need to image. You can tell immediately on B mode. But simple cysts will not enhance in any phase of contrast enhancement. Here's a more complex cyst, though. So there was concern whether this might be a cystic malignancy or an abscess. The patient had vague pain, but nothing else. Nothing really on conventional Doppler there. The CT doesn't really show any of this internal structure at all. But when we gave contrast agents, you can see that the internal contents, there's no enhancement at all. And the wall is very thin. There's no rim enhancement. So this is a complex, simple cyst, but there's no evidence of anything to suggest malignancy, no rim enhancement to suggest this is an abscess. And it was aspirated and just produced old blood. So it must have been a cyst that bled into itself. Again, completely benign, though. So hemangiomas are the commonest benign tumor. They consist of dilated vascular spaces separated by fibrous septa. They show peripheral globular enhancement on contrast ultrasound with central pedal fill-in. Some may have atypical features where they have partial fill-in due to thrombosis, fibrosis, or necrosis. This tends to be the bigger lesions, but the bottom line is that the lesion will be smaller on contrast ultrasound compared to B mode. And then there's another common variant, the high flow variant. We get rapid homogeneous enhancement, so the flash fill type hemangioma. So here's a little hemangioma here. So you can see on B mode, it's not entirely typical in appearance, but it shows peripheral globular enhancement and fills in quite rapidly while we watch there. And then you can see at 5 minutes, it's completely disappeared. And you can sort of measure where you think the lesion is, and it will co-register to the other screen. So no washout. So that's a classic hemangioma, nothing more to do. Now, this looks like a big aggressive lesion on B mode, and it could be absolutely anything. When we gave contrast, though, it immediately has this classic peripheral globular enhancement and shows partial fill-in as we go through and no washout. And as I say, it's smaller on contrast ultrasound than the B mode, so we can be confident that with this classic enhancement pattern, and its appearance that this is a large hemangioma. So as I said, the central bit probably doesn't fill in due to necrosis, fibrosis, or thrombosis. Now here's a little small echogenic thing here. Now normally you'd call this just a hemangioma on B mode, but the patient had breast cancer. So we had to characterize it further. And you can see with contrast, it avidly enhances immediately, homogeneously, and then disappears and doesn't wash out. So again, this is a classic hemangioma. Now, this is the sort of thing that's difficult on MR and CT because it's sub-centimeter. And as I said earlier, MR and CT doesn't have the spatial resolution that we have on ultrasound. So it would come back as an indeterminate lesion on CT, and it's quite a big referral pathway that we get to characterize these small lesions on MR and CT, especially when there's a primary malignancy. Now, here's another patient that's got a fatty liver, and you can see these two liver lesions here. They're echo poor, have a slightly irregular margin, and it could be absolutely anything. But when we give contrast, you can see that immediately they both show peripheral globular enhancement and fill in as we watch. And there's the late phase there, so they've completely filled in, didn't wash out. So that's two hemangiomas, and you get this apparent inversion of echogenicity on B mode when you've got a fatty liver, but a classic enhancement pattern again, so we could reassure the patient. Is a calcified lesion that's slightly exophytic on B mode. Give it some contrast. And again, peripheral globular enhancements, classic enhancement. So it doesn't fill in completely, and that may be because you've got some central calcification or fibrosis. But whatever it looks like on B mode, it always has this classic pattern on contrast ultrasound, which is a great advantage to us because we're always problem solving when lesions look a bit atypical on B mode. Here's two hemangiomas, again, classic enhancement pattern. And you can do this flash and capture on most of the vendors now, where you get a kind of layering of the contrast as it comes through, a sort of a MIP effect. And this can be used to see the direction of flow of contrast, and is useful for determining whether the bubbles are coming in from the outside or coming in from a central vessel. Now, how about this liver lesion here? So this was thought to be a hemangioma, but it's slightly atypical. You've got some shadow in there, very unusual. So gave contrast, Now it's enhancing. So that's not a pattern that you'd see with hemangioma. So it enhances in the arterial phase, and then we're at 1 second, 1 minute 20, it's already washed out. So this is a malignant pattern. So the patient had further investigations, and it turns out this is a metastasis from a colon cancer. So the calcification was due to the fact that it's a mucinous cancer with some sort of micro calcification there. So the other common focal benign lesion that we've seen is focal nodular hyperplasia. This is thought to be a hyperplastic response to a congenital AVM. And on contrast ultrasound, you see this avid enhancement from a central feeding vessel, which spreads out before your eyes in a centrifugal spoke wheel pattern. It remains echogenic or isoechoic in the late phase, does not wash out, and you can have a central scar in up to 25%. So very, very subtle liver lesion here on B mode, and giving contrast avidly enhances immediately from a central feeding vessel, although it can be tricky to see on this. So I used a higher frequency 9-2 probe, and I give it a flash with a high energy pulse there coming up soon. And then it shows, you can see now a beautiful spoke wheel pattern that comes from that central feeding vessel in a centrifugal manner. And then, of course, we follow it into the late phase. It doesn't wash out, and it's got this small central scar. So it's a classic focal nodular hyperplasia. Now, the enhancement can be so rapid that you may need to take your video and just rewind slowly, frame by frame, to look and see what happened from the word go. So you can see at 5 seconds, 7 seconds, 10 seconds, and 19 seconds. And you see this vessel, the feeding vessel centrally, which grows out in a centrifugal manner, and then just disappears and then does not wash out. So this is a beautiful depiction of focal nodular hyperplasia and the enhancement pattern in the arterial phase. You can also do this by parametric means by looking at the arrival time of contrast. And you can see here that you've given you've got the time of arrival at 2 seconds to 8 seconds, and the central spoke wheel enhancement is early arriving at the liver lesion and then spreads out into this classic spoke wheel pattern. So that's quite a nice depiction of the spoke wheel there. So other common things that we see are focal fatty sparing and focal fatty change. And focal fatty sparing is usually classic and is in the gallbladder bed or adjacent to the porta hepatis, and you don't need contrast. Similarly, focal fatty change is usually a focal liver lesion. And on contrast ultrasound, the enhancement is isoechoic to the adjacent liver in all phases of enhancements. So unfortunately, of course, you always get tricky cases. And here's a patient with a fatty liver, and they've got these echo-poor liver lesions throughout the liver. And when we give contrast, you can see that none of them wash out. So this is multifocal fatty sparing, but all benign, whereas initially we thought this was going to be a malignancy. And here's an example of focal fatty change where you've got no washout in the late phase. Very reassuring. Adenomas are a bit more tricky on contrast ultrasound because there's 5 types. And they can have a bit of a variable sort of histology and enhancement pattern. There's also a risk of malignancy and hemorrhage. Typically, they enhance in the arterial phase, but unfortunately have variable washout in the late phase. And they may have non-enhancing areas due to necrosis or hemorrhage. So here's one here. It's very echogenic, and this was fatty on MR. And I find that actually MR is better at characterizing adenomas than contrast ultrasound. But due to its benign form, due to form, it's not washed out in the late phase there. So this is a benign lesion, but you'd need MR to characterize it further, usually. Abscess, you usually wouldn't come across this incidentally, but you'd be surprised when patients come in and they're sort of ill, but nobody knows what's going on. They can have a variable imaging appearances due to the degree of liquefaction and loculation. Typically, on ultrasound contrast, they enhance around the rim and internal septa, and contrast ultrasound increases conspicuity. So here we go. This could be anything on B mode, but we give contrast, and now you can see beautiful loculation enhancement of the septa throughout the lesion, and then rim enhancement as well. So this is a classic abscess, and you can decide whether this is drainable or whether it needs aspiration or just antibiotic therapy. Turning to the malignant lesions. Strategy for imaging metastases, again, it's the same as any focal liver lesion. So you look at the arterial phase, the portal phase, and the late phase. And there are two main types of metastases: hypovascular metastases from colon, stomach, pancreas, for example, or hypervascular metastases from melanoma, thyroid, or renal. So here's an interesting case with this patient had hypercalcemia following parathyroidectomy. And here's the liver lesion here. And then when we gave contrast, avid enhancement in the arterial phase. And I switched to a high frequency probe to get even more spatial resolution. And you see beautiful enhancement there. And then it washed out in the late phase. So this is a hypervascular metastasis from a parathyroid carcinoma, which explains the persistent hypercalcemia. So very, very rare. And here it is on CT. You can hardly actually see it. So it just shows the beautiful spatial resolution that we get on ultrasound. Here's a patient with CA ovary, and there's rim enhancement with some enhancement within the lesion. That's not peripheral globular enhancement, that's rim enhancement. And you can see it washes out immediately there by 50 seconds. So again, this is a metastasis, a hypovascular metastasis. Now, this is a very subtle lesion for the experts among you. So here we are, there's a very, very subtle lesion there, subcapsular lesion. And we can give contrast. And now as we watch this lesion enhance, and we're only at sort of 30 something seconds, and now you can see now it's starting to wash out. It's starting to become a defect before your very eyes at 36 seconds. And then at 5 minutes, it's a frank defect. So this is an isoechoic metastasis, very, very subtle. But of course, on contrast ultrasound, these shows defects, which explains why the sensitivity and specificity is markedly increased compared to conventional B mode. Here's a patient that had breast cancer. And as we scroll through in the late phase, you can see all these lesions popping out that you cannot see on the adjacent B mode. Even in retrospect, it's hard to see them. So multiple metastases. And so it's all very worrying. So if you've done an ultrasound in a patient with malignancy and you've come up with normal, then you've done a non-diagnostic scan, unfortunately, because you may miss these subtle lesions. And here's a little lesion I was talking about earlier. We get referrals from MR and CT. So tiny little lesion in the liver. So I scanned through, and in the late phase at 3 minutes 40, I found this little lesion here, 8 millimeters. And then I went back and injected another dose of contrast agent, because now I know where it is, so I can go straight to the lesion. This shows rim enhancements of the lesion, and then we know that it's washed out in the late phase. So despite it being 8 millimeters, we can say categorically that this is a metastasis. But on MR, it could have been hemangioma or anything really. So it just shows you the resolution that we've got using this technique. So there's big problems with ultrasound and liver metastases. The sensitivity for just conventional ultrasound is really low compared to CT. It has trouble with isoechoic or subtle lesions. These sub-centimeter lesions are difficult, and there's a false negative rate quoted up to 30%, which is unacceptable, really. But contrast ultrasound increases the conspicuity of these metastases and therefore the sensitivity and specificity. And one meta-analysis of 45 studies showed a significant rise in sensitivity and specificity to rival that of CT and MR. And the diagnostic accuracy is also increased for these small lesions with contrast agents. So here's a patient, right at the beginning, I talked about you must know about the patient's liver, whether they've got any chronic liver disease. So this patient's got thalassemia, hemosiderosis. So they have got some chronic liver disease, and they've got this liver lesion here, which avidly enhances in the arterial phase. Now, look what happens in the late phase. So at 3 minutes, it's still not washed out. But as we wait a bit longer, at over 4 minutes, it's now washing out. So this is an HCC. So it's a classic example of the later washout on HCC compared to metastases. So you need to scan for longer, sometimes up to 6 or 7 minutes, to make sure it doesn't wash out. Here's a really sort of classic big HCC, and it's got this chaotic basket work type vessel supplied in the arterial phase. And then again, there is washout, but again, there's still some contrast within it. And the poorly differentiated HCC washes out more early than the well-differentiated HCC. So the poorly differentiated HCC is more like a metastasis, really. So this is just the figures from Adrian's excellent book. And it shows that having diagnosed HCC, you can stage it. So we're looking at the portal vein here. So in the arterial phase, it's enhancing. Now that shouldn't happen in a portal vein, as you know. But then as we follow it, it washes out. So this is tumor thrombus in the portal vein. So if it was bland thrombus, there would be no enhancement at all. So this is a bad prognosis for this particular unfortunate patient. Having treated your HCC, you can then follow it up. So this is a patient that's had an ablated HCC, and they've come back for follow-up. And now you can see that there's enhancement within the lesion, unfortunately. So this is recurrence within the lesion. So this technique can be done on the table immediately post-ablation or as a follow-up procedure. Again, this is going to be tricky to detect the recurrence on MR and CT, especially in these small lesions. Chronic liver disease and cirrhosis has a number of nodules. So it's got regenerating nodules and dysplastic nodules. So regenerating nodules are typically isoechoic to the adjacent liver in all phases, but the dysplastic nodules, which are kind of on the spectrum towards frank HCC, may show arterial enhancement and some washout in the late phase. Now here's a cirrhotic liver, really subtle echo pore lesion here. So we gave contrast and it enhanced homogeneously and at the same amount as the adjacent liver. And then we followed it in the late phase and it didn't wash out. And this patient was also followed up, of course, every 6 months for a surveillance. So this is a regenerating nodule. So we can say it's benign, completely benign, but still needs surveillance. Here's a patient who's jaundice with widespread biliary duct dilatation throughout the liver on CT. And then they went for an MRCP, which showed, again, dilated ducts. And these all converge at the hilum of the liver, but no mass could be seen on CT or MR. So we gave some contrast agents, and there's enhancement in the arterial phase. And now you can see that there's a defect at the hilum there. which is developed. And then this was biopsied and was confirmed as a Klatskin cholangiocarcinoma. Here's a patient that had pancreatic cancer, and there was this liver lesion here, and we characterized this as a metastasis on contrast. You can see a defect here. Now, of course, unfortunately, they wanted biopsy proof. And you can see there's aerobilia in the liver, which makes it really, really difficult to see what's going on. But we've got 5 minutes now where we can plan our biopsy, and you see we've taken the biopsy there of the liver lesion and proved that that was a metastasis. So again, the conspicuity of the metastasis is massively improved. And you can use this technique to target viable tumor, avoid necrotic tissue, great for isoechoic lesions, and as part of an image fusion technique. So in conclusion, contrast ultrasound is a really versatile technique. It significantly improves the sensitivity and specificity in ultrasound in the characterization and detection of focal liver lesions derived of CT and MR. Benign lesions retain contrast in the late phase and portal phase, but have specific arterial enhancement patterns. Malignant lesions enhance and wash out. There are numerous advantages of contrast ultrasound over MR and CT. Easy to learn technique, cost effective, and it makes ultrasound fun in that you can get the answer immediately, and more importantly, you can save the patient a lot of anxiety as they avoid a sort of 3-4 week wait for a CT or MR. And thank you very much for your attention.
Thank you, Chris, for that really excellent and comprehensive talk covering such a wide topic in such a small time, and beautiful images. So thank you very much for that. Just a reminder, we're having questions and answers at the end of the session. And so please feel free to type any questions and answers into the chat below for the participants.